We're ready to get started in our first plenary session, which is on new evidence in heart disease, reducing residual risk. We have a great lineup of speakers this morning. And the first one is Ruth McPherson from the University of Ottawa. Ruth is a MD, PhD, clinician scientist, endocrinologist, and really a world-renowned lipid expert, and works on the genetics of coronary artery disease. She's widely published. She's funded by the CIHR and directs the Lipid Clinic and Atherogenomics Laboratory at the University of Ottawa Heart Institute, and really is one of our key Canadian opinion leaders on the world stage. So Ruth, welcome. And you're going to talk about lipid optimization, making the most of available therapies.
Thank you, Dr. Farquhar, and it's a pleasure to be here, even though I had to get up at 4 o'clock in the morning to make my 6 o'clock flight from Ottawa, but maybe I'll do something different next time. Okay. Those are my disclosures, which aren't really all that much. I don't think I have any bias. Okay, what are the objectives? Really to really gain knowledge in terms of making the best therapeutic decisions regarding combination therapy. I think in terms of lipid treatment, it's often easy to get stuck on prescribing a low dose of a statin and staying there, whereas we do have other drugs. We have inexpensive drugs that are effective. We have more expensive drugs that are super expensive, but really do have a place in our therapeutic armamentarium. So we're going to discuss a little bit about the guidelines and what is the target and what is optimum, and that may change over time. And finally, we'll talk about the patient who's really going to develop the most benefit from PCSK9 inhibitor therapy. So, you've all seen these Framingham tables. They're not perfect. There probably are better paradigms for assessing risk, but this is what most of us use, and this is what the CCS guidelines have used as the core of their risk assessment guidelines for several years. But anyway, this is a place to start. It's not, it gives you some overall idea of what the patient's risk is, but we have to remember that risk discrimination is only moderate. So we do see these patients with every risk factor in the book, and if they turn out having a CT angiogram, there's really no plaque at all, and other patients who surprisingly appear to be low risk, but actually do have significant atherosclerosis. We have made the recommendation that, is my thing working? Oh, sorry. That for patients with a family history of coronary disease, particularly premature coronary disease, the calculated risk, be it like 7% or 10%, should be doubled. We know from our genetic studies that the risk for cardiovascular disease is approximately 50% genetic. And what is interesting in terms of the some 302 common genetic variants that we've discovered that increase the risk of coronary heart disease, the vast majority don't relate to conventional risk factors. So there's a lot of genetic risk out there that you're going to miss simply going by conventional risk factors. So in terms of primary prevention, I think this is where decision-making is often the most difficult for many individuals. We have always said the calculated Framingham risk after adjustment for family history is more than 20%, then those patients should be treated with a statin. So there are other groups where the guidelines have also recommended treatment. Patients with a risk factor score between 10 and 20%, or even 5 to 10%, particularly for susceptible populations such as South Asians, such as the indigenous populations in Canada. And for those individuals, the guidelines say, well, treat them if LDL is above 3.5 or greater than 4.3, and I'm not sure if that's really correct. Also based on the HOPE-3 study, so that really important study that was driven out of McMaster, as many of these great studies are, men over 50 and women over the age of 60 who have at least one risk factor. So those were the inclusion criteria for HOPE, and they were treated with a moderate dose of a statin. There was indeed benefit. And finally, we have those individuals who, it doesn't really matter in the Framingham risk factor score, but if the LDL is greater than 5 or if there's a diagnosis of familial hypercholesterolemia. The latter because we're trying to treat individuals with a genetic cause for very high cholesterol starting at an early age, because the lifetime risk of coronary disease is a bit like pack years of smoking. It's life years of exposure to LDL. So those individuals, the guidelines state, should be treated if LDL is greater than 5. Now, the question is that really the appropriate number? So there's a very interesting paper published in Circulation, actually just 2 years ago. And this is from the Cooper Center longitudinal study. So about 30,000 individuals, so a huge population, at recruitment were definitely low risk and followed for 28 years, so really long follow-up. Remember, Framingham risk factor score, we're talking about 10 years, and 10 years doesn't really mean much if you're 40 years old after all. So the interesting thing there is that, as one might anticipate, individuals who had a baseline LDL less than 2.6 were really at quite low risk. Those who had LDLs kind of between 2.6 and 4.1, sort of intermediate. But individuals who had an LDL above 4.1 were really very similar to the group with an LDL greater than 4.9. So these individuals had a markedly increased risk of dying of cardiovascular disease during that 28-year follow-up. So the question here is, waiting until the patient has an LDL of 5 appropriate in terms of treatment, or should we be thinking of treatment with lower LDLs, perhaps 4.1? So I think that is something that we have to keep in mind, and I think we have more and more data when we try to look at lifelong prevention that indeed lower is better, starting really quite early in life. Okay, so these are, the guidelines are currently about to be updated a little. We have getting a committee together right now, but these are the 2016 guidelines. So statin-indicated conditions, just like to review those for a moment. Obviously, clinical atherosclerosis, but we've added abdominal aortic aneurysm, which is, of course, a disorder of atherosclerosis, although there are other factors that contribute. Patients who have diabetes, if they're 40 years of age or older, or have a 15-year history of diabetes with or age over 30 with microvascular complications. So that doesn't encompass everyone with diabetes, but it does encompass the majority of individuals, and it means that we're treating patients with type 1 diabetes much earlier than perhaps we did in the past. So we've also added chronic kidney disease, obviously important, so EGFR less than 60, I mean, most of my patients are in that category, or an ACR greater than 3. And finally, the old LDL greater than 5. So the targets, generally less than 2 for most of these individuals, but certainly even in 2016, we said that those highest risk patients, post-ACS, patients who've had bypass surgery, particularly if they've had saphenous vein grafts, patients who have diabetes and cardiovascular disease, or patients with recurrent events, then LDL should be less than 1.8. So, a few things that I'd like to emphasize, and perhaps we didn't emphasize enough in the last guidelines, although we had non-HDL there as an appropriate target in addition to LDL. So one point I'd like to make is that some of our patients ask for ApoB measurement, and of course that's not covered by OHIP in Ontario, and they have to pay generally $35 for it. But the Emerging Risk Factors collaborations essentially showed that this is non-HDL, the top line, this is ApoB. So those two are equivalent. There's no need to measure ApoB if you have a non-HDL cholesterol. But, and I should like to make the point that non-HDL is really an important target in those patients with mixed dyslipidemia. So when triglycerides are even moderately elevated, we have to remember that the atherogenic particles encompass all of these, LDL, Lp(a), which is a particular risk factor, but the very low density lipoproteins, these particles are triglyceride rich, and certainly they're remnants. So it's the cholesterol in those particles that is atherogenic, and that certainly adds to the information we have with just LDL alone. The other point I'd like to make, and it's still, it doesn't seem to be well acknowledged, is the fact that the paradigm for HDL and risk has changed. So Framingham, the initial Framingham data, really kind of 5,000 people. It was a very small population study. What we know now is that although a low level of HDL is a risk factor for cardiovascular disease, high levels are not protective. And we saw that in actually a Canadian study about 3 years ago, but recently presented at the European Society of Cardiology, the Emory Cardiovascular Biobank. What we saw here is that participants who had an HDL above 1.5 had about a 50% increased risk of death due to cardiovascular disease. So forget the ratio. Use a low HDL as a risk factor, but don't assume that a high HDL is protective. And there may be some reasons for this. You see men with high levels of HDL, it's often due to generous intake of alcohol, which may not be cardioprotective. But irrespective, we've got a lot of data out there showing that high HDL is not protective. So in terms of LDL, lots of data. Lower is better. We've seen that in the statin trials, both primary and secondary prevention, and then more recently in the PCSK9 inhibitor trials, patients with stable coronary disease with evolocumab, as in the Fourier study, patients post-ACS, alirocumab in the Odyssey study. So just to remind you, Prove It, this is a post-ACS study comparing Pravachol to atorvastatin, and really showed, obviously, that lower is better. But what's interesting here, the patients who had the lowest risk of recurrent events, LDLs less than 1, and that was just with statin therapy alone. In the Jupiter study, really important study because this is primary prevention, men and women, there was a 20% decrease in mortality in the group randomized to rosuvastatin 20 milligrams. But if we also look at the data, we see that those randomized to rosuvastatin who achieved an LDL less than 1.3 definitely did best. So remembering targets, when you think about targets, you think of less than. So the better you can do reducing LDL below that target, the better the patient's going to do. And then, of course, with this is a Fourier study with evolocumab, those individuals getting LDLs down to somewhere between 0.5 and 1.0 definitely did the best, and those are patients with stable coronary disease. Okay, treatment of hypercholesterolemia, of course, you know a lot of this. The goal is to upregulate LDL receptors. You do that by decreasing hepatic free cholesterol or by decreasing VLDL assembly and secretion. So we shouldn't forget diet. I mean, diet used to be, these talks when I gave them 25 years ago, I said, you know, diet was a cornerstone of therapy, and I think people have forgotten that. But diet's very important. To decrease the LDL, increase LDL receptor expression on the liver, replace saturated fats with mainly polyunsaturated fats because linoleic acid has the greatest effect in upregulating LDL receptors and decreasing VLDL secretion. Then, of course, we have statins that inhibit cholesterol production. We have ezetimibe that decreases the reabsorption of cholesterol. And bile acid sequestrants, very simple, they decrease bile acid reabsorption, so the liver has to use up cholesterol to make bile acid. So it's very simple from a biochemical point of view. You're just decreasing the amount of cholesterol in the liver. So statin therapy is very effective. I mean, not when you use the tiniest doses, but if you titrate a patient up to 40 milligrams of rosuvastatin or even 80 milligrams of atorvastatin, you can get a 60% decrease in LDL cholesterol. So, you know, that's equivalent to a PCSK9 inhibitor. So PCSK9 inhibitors don't replace statins, they're additive to that therapy. It is true when you double the dose, you get about an additional 6% reduction. And of course, we know from all of the statin data out there that for each 1 millimole reduction in LDL, there is a 22% decrease in cardiovascular events, a 10% reduction in mortality. And of course, we don't normally lower LDL by 1 millimole per liter. We normally lower it by at least 2 and often 3 millimoles per liter. And so this is why, for most cardiovascular patients, we're recommending the highest doses of statins if tolerated and the highest doses of the most effective statins. So statins, really, next to diet, are the cornerstone of therapy. They're inexpensive, they're safe for the vast majority of individuals, lower LDL by up to 60%, reduce MACE by 50% over 3 to 5 years, that was the Jupiter study, reduce mortality, women and men, individuals with low or high LDL cholesterol, primary and secondary prevention. The other point I'd like to make today is because you all have patients they've had their myocardial infarction and they're back in your clinic, but they're complaining of muscle discomfort. So what we know, and this is based on recent data and older data, this is a study published in Circ actually 16 years ago, if you can believe it. So in patients presenting with acute coronary syndrome, pre-treatment with statin was associated with a 50% lower event rate compared to patients who were not on a statin. Whereas patients who were in a statin and discontinued statin treatment following ACS, there was a 3-fold increase in the risk of death or MI. And that occurred very, very quickly. This is a 30-day study. So if a patient is complaining of side effects, do not stop the statin unless they actually have frank rhabdomyolysis. Perhaps reduce the dose a bit, but certainly stopping is not appropriate. And of course, a lot of patients, their major doctor is Dr. Google, I'm sorry, rather than you. And so this is a very nice study from the Copenhagen group. In Denmark, of course, they have very good data on population and sort of ongoing data on outcomes. So this study demonstrated that negative statin-related news stories decrease the use of statin. This is likely of discontinuing statin therapy. The positive news stories increased adherence, but there's not many of those, as we know. And really what it showed is that for those patients who discontinued statin therapy, there was a definite increase in cardiovascular events, and this occurred actually very quickly. So statins are something to continue, particularly when there's documented CAD. So what about non-statin agents? Ezetimibe, useful second agent, bile acid sequestrants. You know, there's a little bit of a niche there. They're relatively expensive for what they do. And then PCSK9 inhibitors. So ezetimibe lowers LDL by another 15 to 20%. There should be a 10% reduction in major CV events in statin-treated individuals. It's inexpensive and really well tolerated. So that was the IMPROVE-IT study. Patients were already on simvastatin 40 milligrams, and they had achieved a LDL of 1.8 millimoles per liter, got down to 1.4 with the addition of ezetimibe. And there was overall a 10% decrease in cardiovascular death, non-fatal MI. Actually, there's a 20% decrease in the risk of stroke. So, you know, this agent does have evidence, and it is inexpensive. It's really, I think, the second-line agent for most individuals. So what about PCSK9 inhibitors? I mean, these are really kind of neat drugs, and there's a Canadian story behind this because, you know, the invention, a lot of it's attributed to Nabil Sida at the Clinical Research Institute in Montreal. So this little cartoon really sort of indicates what's happening on the liver. So basically, the paradigm has been that LDL binds to the LDL receptor, and that is endocytosed, and there's a recycling endosome, where Brown and Goldstein got the Nobel Prize for this many years ago. The paradigm was that in the recycling endosome, the LDL receptor would recycle back to the plasma membrane, whereas the LDL was simply degraded. Well, what we know now that we didn't know then is that the liver also makes PCSK9 for reasons that are not absolutely clear, but it's often true in biology that these things happen. So PCSK9 is secreted, and what PCSK9 does is to bind to the LDL receptor LDL complex. The whole thing is internalized, and when PCSK9 is there, the receptor does not recycle, rather it is degraded. So fewer LDL receptors on the surface of the hepatocyte. So PCSK9 has not been easily amenable to small molecule inhibition. People are still working on that, but the most effective way to reduce PCSK9 activity for the moment is an antibody. So the monoclonal antibodies bind to PCSK9 in the circulation, they get it out of the picture, and the LDL receptor basically recycles. So we've had good data there. The Fourier study, this was the addition of PCSK9 inhibitor to a statin in stable cardiovascular disease, and basically what we saw was about a 60% reduction in LDL, and the primary endpoint, cardiovascular death, MI, and stroke, was reduced by 15% over a 3-year period, so definitely additional benefit. And the secondary endpoint, which was more the sort of more pertinent things, cardiovascular death, MI, or stroke, there was overall a 20% reduction. And once again, we saw very clearly patients who achieved the lowest levels of LDL did the best. And finally, more recently, post-ACS, this was a study with alirocumab, the other PCSK9 inhibitor available in Canada, patients who had had an ACS event 1 to 12 months before randomization. And in this study, similar reduction in LDL, overall about a 15% decrease in the primary endpoint. There actually was a decrease in all-cause death. It wasn't significant just because of the way they did the analyses, because it was a stepwise, but you know, we were seeing in these high-risk patients a benefit in terms of death. And that study showed that the subgroup who on a statin therapy post-ACS with an LDL above 2.6 really benefited the most. In fact, overall, there was a 30% decrease in death and a 25% decrease in MACE, so really very exciting results. So PCSK9 pyramid, I mean, a lot of it is getting covered for the patient. These drugs are expensive, but they're becoming less expensive very quickly. Obviously, patients with severe genetic dyslipidemia with atherosclerosis. So FH patients covered by most drug plans. ODB will cover them if they also have cardiovascular disease and an LDL above 2 on statin therapy. I think patients with aggressive CAD, despite maximum treatment, are an important group that should be treated. Coverage, of course, varies by the drug plan. And then we move on, perhaps an LDL greater than 2.6, looking at the Odyssey outcome study, LDL greater than 2 in terms of what is actually optimal. Okay, these are the take-home messages. Statins, the cornerstone of therapy for lipid lowering and cardiovascular prevention. Ezetimibe is a useful and really underutilized second agent, supportive RCT data. We have more and more evidence that lower than the guideline targets is definitely better. Many high-risk individuals don't actually achieve these ideal LDL levels, so definitely there is a role for PCSK9 inhibitors in optimizing treatment. Thank you. I think, Dr. Farquhar, we're going to leave the questions for the end. Okay, very good. Thank you.
Thank you, Ruth, for a wonderful overview. And we'll have questions again at the end of this session. Our next speaker is John Eikelboom from McMaster University and the Thrombosis Service, Hamilton General Hospital, and the Population Health Research Institute. John is really a world leader in thrombosis, in research, both with landmark studies to his credit, and he'll highlight one of them and a few of them hopefully today. John is a co-author of more than 500 peer-reviewed papers and is highly funded by multiple agencies, including the Heart and Stroke Foundation. And his real focus is on the efficacy and safety of antithrombotic therapies, outcomes in blood transfusion and bleeding, and the mechanisms of various responses to antiplatelet drugs. John, welcome.
Hi. Thanks very much, and good morning, everyone. I don't remember being as inspired by the start of a meeting as this morning. You know, hearing about the program in the mosque, which I thought was absolutely fabulous, and then the little workout was great. So I'm not going to be able to emulate that, and nor am I going to be able to emulate the great lipid data. But there is sensational new information, I believe, in antithrombotic therapy for long-term secondary prevention, with a very simple adjustment of our current approach to antithrombotic therapy for long-term secondary prevention. We can achieve reductions in MACE and mortality that brings antithrombotic therapy well into the realm of the heavy hitters, the statins, blood pressure lowering, ACE inhibition for long-term secondary prevention. Aspirin's been a great treatment, but it's only modestly effective. But I will show you the data, and many of you may be familiar with the high-level data, but I'll show you the data on rivaroxaban 2.5 milligrams and how you might integrate that information into your clinical practice. My disclosures are here, and I was one of the co-principal investigators on the COMPASS trial, which tested rivaroxaban for this indication. Now, it probably is not necessary to remind you, but I'll do it anyway. Cardiovascular disease, yes, we're making great inroads in prevention and treatment, but it's still the #1 killer. There are over 300 million people worldwide affected. And in our vast country, Canada, we have more than 1 million of our fellow countrymen affected. 1 in 25 people, I'm guessing in this room, there are a few dozen people with cardiovascular disease. There's no doubt that blood pressure lowering, that ACE inhibition, that lipid lowering therapy, and I should have prefaced all that healthy lifestyle, that regular exercise, that good nutrition can reduce the burden of cardiovascular disease. But ultimately, the final pathway that leads from atherosclerosis to acute myocardial infarction, to acute stroke, and to acute limb ischemia is thrombosis. And so it makes a lot of sense to try to better modulate this final pathway to prevent cardiovascular events. Aspirin has been the foundation. It produces about a 19% relative risk reduction during long-term treatment and about a 10% reduction in mortality, about the same as lowering LDL cholesterol by 1 millimole per litre. But clearly, we can do better, because even with aspirin, in patients with a history of atherothrombotic events, there is persistent residual risk, and there is persistent platelet and coagulation activation. Here is the list of treatments that are accessible to you. There are many such treatments, and I won't go through them in any detail, but my focus is going to be on this lower end of this list, on optimizing antithrombotic therapies. And so back in 2011, we began work to implement a randomized trial with alternative antithrombotic strategies to aspirin. And those of you who have been around in the antithrombotic world for a couple of decades will recall efforts to improve on aspirin using clopidogrel, using the combination of aspirin and clopidogrel, and then more recently using ticagrelor or prasugrel. And in the acute phase, we've done very well with these alternative approaches. But in the long-term phase, most of these studies have not been successful. They've shown either no benefits or a bit of reduction in non-fatal events, with an increase in bleeding and no mortality benefit. So we set out to test rivaroxaban at low doses, rivaroxaban 2.5 milligrams twice daily, that is half the prophylactic dose for venous thrombosis, in combination with aspirin. Rivaroxaban 5 milligrams twice daily, the prophylactic dose, and dropping aspirin, or aspirin alone. In a second factorial randomization, we tested proton pump inhibitors to prevent GI bleeding. A little bit more on that later. We expected the study to go for 3 to 4 years, but after 2 years, the DSMB said, we recommend you stop. The benefits of rivaroxaban plus aspirin are so large and compelling, they're so robust, that we need to get this treatment out to patients as rapidly as possible. Rivaroxaban alone was not superior to aspirin, and for the rest of my presentation, I'll essentially ignore that part of the study. Rivaroxaban was as effective when used alone, but caused more bleeding. So here are the results, and you're all familiar with these kinds of graphs, and you see two curves, and you see they kind of separate towards the end, and you could be forgiven for thinking, well, you know, so what? Still a lot of residual risk, yet another treatment. What am I going to do with this stuff? My head's full of statins and ACE inhibitors and beta blockers and aspirin. And well, a little bit more about these results. The black line is rivaroxaban plus aspirin. The red line is aspirin. It's about a quarter reduction in major adverse cardiovascular events. Again, of the ballpark of a 1 millimole reduction in LDL cholesterol, of a 10 millimeter drop in blood pressure, of the use of an ACE inhibitor. Now, if you're in your clinic on Monday morning and your average chronic atherosclerosis patient who is apparently stable walks in the door and you think they're doing well, they're on a statin, they're on blood pressure lowering and ACE inhibition and aspirin, and you ask that patient, what do you fear the most in terms of complications of your atherosclerosis? I wonder what they might answer. And we really need our first speaker up on the podium here to tell us what he would have said, because I suspect that the complications they fear the most are: 1, I don't want to have a stroke; 2, with peripheral artery disease, I do not want my leg amputated; and 3, as long as I don't stroke or have an amputation, I would like to stay alive. Well, in the COMPASS trial, I'm pleased to say that we achieved that trifecta. Perhaps for the first time demonstrated that we reduced stroke, ischemic stroke, by almost 50%. My colleagues in stroke medicine are green with envy that we did a study of a drug to prevent cardiovascular events, that we can reduce ischemic stroke by almost 50%. We reduced amputations by 50%. When's the last time you could go to a vascular patient and say, not only do we reduce stroke, but I can stop you losing your limb? And finally, we reduced mortality by 18%. Here are the data. Overall, a 42% reduction in stroke, a 49% reduction in ischemic stroke, a small numerical but non-significant excess of hemorrhagic stroke, 15 versus 10 events. For peripheral limb outcomes, an almost 50% reduction in major adverse limb events and a 50% reduction in amputation. Very low numbers, but a robust treatment effect. And mortality, 4.1% down to 3.4%, an 18% mortality reduction. And remember that if you lower LDL cholesterol by 1 millimole, you get about a 10% mortality benefit. If you lower blood pressure by 10 millimeters of mercury, you get a 13 or 14% risk reduction. Here you're getting an 18% reduction on top of statins, blood pressure lowering, ACE inhibition. Just to put that in context, and I've just mentioned the context, as you go from left to right on the screen, the COMPASS regimen, 1 millimole reduction in LDL cholesterol, a 10 millimeter reduction in blood pressure and ACE inhibition. And the triple outcome, mortality and stroke, stack up very nicely amongst the big players for long-term secondary prevention. The MI reduction is not significant in COMPASS, but it's almost in the ballpark of blood pressure lowering. And then we've got the male reduction by 46%. These results prompted Health Canada to label the combination of rivaroxaban and aspirin in September of this year, not just for reduction in MACE, but specifically for prevention of acute limb ischemia and mortality in your coronary patient with or without peripheral artery disease. So the challenge is clear. Whether you are fast adopters of new treatments or whether you are more measured in your adoption of new therapies, I'd suggest to you that you need to make an explicit decision for all of your vascular patients in the same way that you consider lipid lowering. Should I or should I not add rivaroxaban 2.5 milligrams to aspirin for my apparently stable chronic atherothrombosis patient with peripheral artery disease or coronary artery disease? So let's think a little bit more about that. As clinicians, we automatically go for where the biggest bang for the buck is. And with adding rivaroxaban to aspirin, we pay in terms of bleeding, which is increased by 70%. More on that later. But when we consider the absolute benefits, these are going to be greatest in those patients at highest baseline risk. Now, the simple way to identify those at highest risk is to go to the primary paper, look at the subgroups, and examine the event rates in the control group. Those with the highest event rates in the control group, if they get a consistent relative risk reduction, are going to get the greatest absolute benefits and the lowest numbers needed to treat. Sonia Anand has also done separately some modeling using two approaches to identify this high-risk population. I won't go through it in any detail, but one approach she used was with the REACH registry risk score, where she divided the population into those with an absolute risk over 2 years, above the median and below the median. And the second approach that she used was a regression analysis, where you essentially let the algorithm, the computerized algorithm, select out those risk profiles that independently predict risk. I'll show you just one example of the latter, and this is called a CART analysis. And at the top of the slide, the first item that emerged was disease involving at least 2 vascular beds. If the answer to this was yes, you were at high risk of subsequent cardiovascular events, amongst the highest risk, and you got the greatest benefit from adding rivaroxaban to aspirin. That risk could be further characterized if you had impaired renal function. You were absolutely the highest risk, that is combined with 2 vascular beds, or if you had heart failure of mild or moderate severity, another very high-risk population. If there was only 1 vascular bed involved, then the presence of heart failure identified a high-risk group. The presence of diabetes was the next highest risk, followed by chronic kidney disease stage 3. To put this together, well, before I put it all together, this illustrates the absolute benefits in terms of major adverse cardiovascular events prevented per 1,000 patients, and the absolute risk increase in terms of serious bleeds for those with at least 2 vascular beds, for those with 1 vascular bed, for those with heart failure, without heart failure, renal disease, no chronic kidney disease, diabetes, no diabetes. The simple summary is as follows. If you have a patient with vascular disease who is apparently stable, who is well treated with statins, the blood pressure is well controlled, they're on an ACE inhibitor, and you would like to further reduce risk with the use of rivaroxaban, you will get your biggest bang for your buck by treating the polyvascular patient, coronary plus peripheral disease, aortic disease plus coronary disease, peripheral disease plus cerebrovascular disease, followed by people with peripheral artery disease, followed by your coronary patient with mild or moderate heart failure, your coronary patient with renal impairment, and your coronary patient with diabetes. So that's probably the most useful information for you, the clinician, in applying this therapy. But there is one important controversy that, in particular, invasive cardiologists will highlight to you. And they may say to you, well, in a post-revascularization setting, in a patient who's had stenting, we also have a treatment called DAPT. And maybe dual antiplatelet therapy should be the preferred treatment in those patients for long-term secondary prevention. I'll show you a few analyses that may help to inform the appropriate management of such patients. And this is ahead of the guidelines, and we will get guidelines in the future that will address this issue. Now, I want to emphasize that this is not a battle of two treatments, but this is using treatments in a complementary fashion to optimize secondary prevention. If we consider the COMPASS trial, in total there were 27,000 patients, of whom 16,000 had a history of MI. And they were recruited within 1 year, about 1,200. In the second year, another 2,000. In the third to fifth year, another 5,000. And beyond 5 years, another 8,000. If we look at the treatment effects of rivaroxaban plus aspirin versus aspirin by year of recruitment post-MI, we see very consistent reductions in major adverse cardiovascular events, somewhere between 20 and 30%. So it doesn't matter when you start this dual pathway treatment with rivaroxaban. In the post-MI setting, you will achieve substantial benefits. Now, the purist here will say, that's interesting, but we can't do indirect comparisons with DAPT because we all know that indirect comparisons are not methodologically rigorous, they're observational, and they're fraught with difficulty. And I acknowledge that immediately. However, as clinicians, each and every one of us has to make recommendations for patients. And as we do so, we indirectly compare information and consider how best to apply that to our patient. If we look at the DAPT data, 1 year post-myocardial infarction, meta-analysis 2016, we see that continuing DAPT beyond 1 year produces about a 22% reduction in MACE. In COMPASS, in your 16,000 patients, of whom about 2/3 got either R plus A versus A, there was a 26% reduction in MI. So these are quite comparable. For cardiovascular mortality, we're getting a 1/3 reduction with the COMPASS regimen, a 15% reduction with DAPT. For MI, clearly DAPT is more effective than the dual pathway therapy, about double the treatment effect. Whereas for stroke, this is reversed, 39% versus 19%. Major bleeding, it's pretty much a wash. They're about the same. But here's where the contrasts really become evident. When we look at total mortality, if we apply a dual pathway therapy 1 year post-MI, we get a 1/4 reduction in mortality. a really striking result. If we do the same with DAPT, no single study has shown a mortality reduction. And when we meta-analyze the post-MI data, there is an 8% reduction in mortality, which is not significant. At very least, the dual pathway approach needs to be a consideration 1 year post-MI in your stented patient on dual antiplatelet therapy. Here is a possible approach that you might use. A patient has an acute coronary syndrome. In that first year, there is a clear and compelling case to be made for dual antiplatelet therapy. If they're very high risk of bleeding, then one might consider dropping back to aspirin alone before the end of the year. For those who get to 1 year, the evaluation might be, what is my patient's ischemic risk? If it's high, I'm going to continue on either DAPT or dual pathway approach. If the ischemic risk is dominated by concerns about stent thrombosis, a pretty uncommon consideration in 2018, then perhaps DAPT should be preferred. If the high ischemic risk is driven by the burden of atherothrombosis, then in terms of antithrombotic therapy, a dual pathway approach may be preferred. I'm going to end with a few comments on bleeding. And up until now, I've said very little about the downsides of dual pathway therapy. There is no doubt that adding rivaroxaban to aspirin increases bleeding. In fact, there is a doubling of the risk of GI bleeding. Although no increase in intracranial bleeding, no increase in other critical organ bleeding, and no significant increase in any other type of bleeding except skin bleeding. But this is where all the action is. Now, it's fascinating that although there is a clear increase in GI bleeding, almost all of the excess occurs in the first year, 3% versus 1.3%. In the second year, it's just about a wash. In the third year, it's about 1% per year in both treatment groups. We looked in more detail at the impact of bleeding on outcome. And in particular, we looked at the effect on cancer. In the COMPASS trial, there were more cancers than there were myocardial infarctions. New diagnosis of cancer, 1,000 subjects, 307 new GI cancers. We then looked at GI bleeding and GI cancer diagnosis. Of the 307 new GI cancers, 70 were diagnosed after any type of GI bleeding, mild, moderate, or severe, a 7.8% rate of cancer diagnosis. In the absence of bleeding, the rate of new GI cancer diagnosis was about 1%, a hazard of 12.9. In other words, there's clearly an excess of bleeding, but for every 13 patients who experiences GI bleeding, we'll diagnose one new cancer. Because GI bleeding is front-loaded, this also means that the GI cancer diagnosis is front-loaded. The numbers are very small, but in the first year, there are 22 new GI cancers in the combo group and just 8 in the aspirin group. Mr. Chairman, ladies and gentlemen, I've given you a very rapid thumbnail sketch of new data from the COMPASS trial where we tested an alternative to aspirin for long-term secondary prevention. I'd put the case to you that today this treatment should join statins, beta blockers, and ACE inhibitors, as well as a healthy lifestyle, including good nutrition, as one of the foundations of long-term secondary therapy. And I hope that the framework I've given you about selecting the highest risk patient, the polyvascular patient, the PAD patient, the CAD plus diabetes, heart failure, or kidney disease, will help you to use this therapy where you get the biggest bang for the buck in those at highest baseline risk. Thank you very much for your attention.